Thank you for downloading Children's Pedcast, a conversation about pediatrics with Children's Minnesota. My name is Jimmy Bellamy, and this week my guests are Drs. Yvonne Eisler, Daniel LaGrange, and Julie Lesser. Drs. LaGrange and Eisler are respectively former student and teacher, and they are world-renowned eating disorders experts. It was a pleasure to have both of them on the show at the same time. They are here in Minnesota for a speaker series at the Center for the Treatment of Eating Disorders here at Children's Minnesota. And Dr. Eisler is from King's College London and Maudsley Hospital. He's also the chief architect for Maudsley Family Therapy, the treatment of eating disorders and implementing a multifamily system. And Dr. LaGrange, of course, a returning guest, which is also another exciting aspect for the show, and he is from the University of California, San Francisco. And we talk about empowering families to successfully treat eating disorders, talking about what research is being done in the field to improve patient outcomes, how the standard of care for kids and teenagers with eating disorders is changing with the new science-based treatments that keep patient families close without disrupting, or at least with minimal disruption, of everyday family life throughout the recovery process. And we also talk about, the how and the why of the development of eating disorders. It was a great conversation, and I was looking forward to this. I had it on my calendar for a while, so now that it's here, very exciting. So sit back, enjoy the show, and just learn from three experts in the field who are talking about a topic incredibly important to the health and well-being of families, kids, teenagers. Thank you guys for being here. It's much appreciated. I'm interested in this topic, and I know our listeners are as well. First, I want to know how long has the family aspect of treating eating disorders been a part of the treatment process?
Well, I guess you probably need to go back to the mid-70s, although people have talked about families, from the end of the 19th century, but at that time they talked about excluding the family because people did better if the family wasn't around. I think really it's the mid-70s when particularly Salvador Minuchin in Philadelphia developed a way of thinking about families, although at that time, not that he thought that families caused anorexia, but he thought that there was a particular family constellation that was the sort of setting where anorexia would develop, but in order for it to develop, he also argued that the child had to have particular vulnerability. But that certainly was really the starting point from which probably a lot of the current treatments were derived.
And in the simplest of terms, or even if it is complex, how and why is an eating disorder developed?
How long do we have? I don't think we have a clear answer to how. What we do know quite a lot about now is some of the things that make people more vulnerable, and they're to do with genetics, with temperament. So people who develop an eating disorder more likely to be people who tend to get anxious. They tend to be a bit more perfectionist. Their thinking styles are a bit different. The way they learn is a bit different. Now, a lot of those things are actually pluses. So, perfectionism is, in principle, no bad thing unless you have too much of it. But it does make you vulnerable to certain things. So it's that a key factor is simply dieting, although without the other conditions, dieting doesn't lead to anorexia. But there's certain things about, being in a state of eventually starvation that actually drives some of these things, and actually also makes the vulnerabilities, say, the perfectionism or liking things to be fairly predictable, disliking uncertainty, starvation makes them worse. So a vicious circle is set up.
What's presently being done in terms of research in regard to patient outcomes?
Well, quite a lot. So I think we know a fair bit now about what treatments work. We know very little how they work or why they work. I'm now talking about children and adolescents, different with adults. But for children and adolescents, particularly for anorexia, there's probably how many trials? About a dozen trials, 10, 12 trials with adolescents, showing more than anything else that a family intervention, but not of the kind that Minuchin developed, but an intervention that basically brings the family in as part of the solution. So you don't treat a family because there's something wrong with them. You help them to rediscover what they're good at. Because part of what happens around something like anorexia is that the family changes. So if you're living with a potentially life-threatening illness, you become different. You respond differently. And some of those changes, they first and foremost, they paralyze the family. So what they normally can do well as parents disappears out of sight for them. So a lot of what you have to do is to sort of dig deep and find that and help the family to remember what they can do. So that kind of approach is really the one that is at the forefront of what we know works for children and adolescents.
How is some of that science-based treatment changing the care that's implemented in helping teens and kids who are experiencing anorexia?
I think fairly fundamentally, because if you look historically, and a lot of it still remains, the treatment of choice with somebody who was suffering from anorexia in particular was to bring them into hospital or residential program, and you bring them up to a healthy weight. And that's pretty effective in the short term. The trouble is that if you do that in that sort of environment, first time round, 25 to 30% relapse within a year. If they go in more than once, the relapse rates are 50, 75%. The difference when you do it outside of a residential setting with the family support is that on the whole, people who get back to a physically well state, who re-nourished, they stay well. And there's still a lot more work to do, but that, I think, is transforming our ability to help. So I know, for instance, we've looked at this in our service in London at the Maudsley. About 80% of the people we see after an average of 1 year's treatment, we discharge back to primary care, and they don't need any more treatment for eating disorders. They may need help with other areas such as depression and anxiety, which may be there like for anybody else. But 80%, if we were doing that consistently everywhere, I think we'd be doing pretty well.
When it comes to Maudsley family therapy, we've seen it implemented all over the world. Yeah. Are there any distinct differences from country to country that have been noticed in the way the therapy is implemented, or even in some of the outcomes?
Interesting question. I'm not sure that in the way the therapy is implemented there are differences, but there are huge differences in the way that health services are organized. So, if you contrast the US and the UK, or Daniel Grange has done a lot of work in Australia, the context in which these treatments are applied are so different. And that makes a huge difference to outcomes. So some of the things that we do in London would be difficult to do here because the way in which treatments are funded are so different. And that's something that I think we're only beginning to look at now, that in some ways changing the service context may be one of the key differences. So if you have a child who's maybe just beginning to possibly develop an eating disorder, we have data in England which shows that if they go straight to a specialist community-based service, first of all, they identify very quickly that way. Their chances of having to go into hospital are 50% or more lower than if they go to a non-specialist. And it's one of the things that, in other areas of medicine, if you have the smallest hint of cancer, you're going to go to an oncologist. You're not going to go to your local physician.
Mm-hmm.
Yet, in mental health, we say, go and see somebody near to where you live. So those things make a huge difference. Probably more than, I would guess that they make more of a difference overall than the particular treatment. Getting there quickly, before the illness really takes hold, and with somebody who has expertise in the area, like anywhere else you look in medicine, is probably the best chance of helping people and making sure that they really don't end up being chronically ill or worse. One of the developments that I think is exciting people is that instead of just working with families singly, which is the way this treatment developed, increasingly we're finding that one way of helping families is that you bring a whole group of families together, and that magnifies their ability to help, probably more than anything else, because they learn from each other, and that sense of we can't do anything, that sense of paralysis, is overcome much more quickly if we're with other families who know what it's like. And so, something that seems completely impossible to one family, another family says, yeah, we used to think that, but we've started doing it. And that, for me, has been probably the biggest shift in my thinking about what we do, because you spend time with a group of families and you really learn what it's like in a way that I don't think I've ever experienced before. And that's something that is coming to Minnesota.
Dr. Lagrange, what has it been like to be able to work with this team, and what have you seen out of the Center for the Treatment of Eating Disorders here at Children's Minnesota since you visited in the past year?
I continue to be impressed by the energy and enthusiasm of this team. I'm impressed by the sheer numbers that they see on a regular basis. This is quite a busy program, and it thoroughly delights me that as a team, evidence-based work is embraced in the way that they do, and the commitment to adherence to treatment models, I think is quite unique. And so that whole package together really provides kids in Minnesota a great opportunity to get good treatment if they have an eating disorder.
Dr. Lagrange, I would like to know what it was like to train with Dr. Eisler, and then maybe just to express the gratitude on behalf of our community and our team, because now we have both of you here, and I don't think it gets better than that.
That's a great question, and it's been 30 years since Yvonne and I first met. He was my mentor. I was his student, and I'll tell you one anecdote that always sticks in my head. Other than all the wonderful things that I learned from Yvonne and continue to learn from him, but we have very different styles in terms of organizing our offices. I'm very tidy. Yvonne is not quite as tidy.
I have what Daniel describes a desktop filing system.
and so while I was doing my PhD, and Yvonne was my advisor, and so I was, and this is in the 80s, so computers were not really as important as they are today. So you do a lot of things maybe on a computer, then you print it out and you give it to someone to read. And I was at the stage where I was churning out my chapters, and Yvonne had to read them. And if you know Yvonne's filing system on his desk, so I would take the bus from wherever I was living in London. It takes me a while to get there, to be there at 8 o'clock so that I can put my next chapter on top of this heap of papers on his desk. And I don't know whether you know this, Yvonne, but then I would go in at 10 o'clock, he's not in his office, and I'd find my chapter sort of somewhere in the middle of this heap of stuff now. And I would go through it and find it and pull it out and put it back on top again. And so I would do that a couple of times during the day so I can keep my chapter on top of the pile so that Yvonne can get to read it quickly. So that was the one of the fun parts of being a student.
What Daniel didn't know is that by putting it on top meant that I could never find anything.
And I mean, you had a system and it worked for you, right? I mean, it made sense.
Mostly.
It to have both of you here has been a pleasure and an honor, and I appreciate you giving us what time you have because I know how sensitive it is. So thank you very much.
Thank you for having us.
Thank you.